Hello and welcome to this week's ECG of the week. Take a second to pause the video here and review the clinical vignette. Okay, let's look at her ECG now. We'll be using the 6-step method to interpret the ECG. You can find this method on our ECG basics video that's been posted on our YouTube channel and on our Facebook page. Okay, the first step is to determine the rate, and there's two different methods to determine the rate depending on whether or not the rhythm is regular or irregular. So let's look at the rhythm. Zooming in here, we're going to identify the QRS complexes first. And now let's look at the distance between the QRS complexes. So here, there seems to be a distance of about 4 big boxes. So 1, 2, 3, 4. It's similar here as well. 1, 2, 3, 4. And that's the same case throughout the entire ECG strip. So the rhythm is regular. And because the rhythm is regular, we can use the 300 method to calculate the rate. And for this, we divide 300 by the number of boxes between the QRS complexes. So 300 divided by 4 is 75 beats per minute. Okay, so the next step is to determine the rhythm. We've already established that the rhythm is regular. The next step here is to look for P waves. So we expect to find the P waves normally before the QRS complexes. However, in this case, the P waves seem to be missing. So there's no P waves here, 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 and throughout the rest of the ECG strip. Okay, the next step is to look for the PR interval. Because there are no P waves, we're unable to calculate the PR interval. Next, we look for QRS duration. And for this, let's zoom in a bit more and identify the QRS complex. So it's from here to about here. And it is 1, 2, 3, 4 small boxes. Each small box corresponds to 40 milliseconds. And there's 4 of them, so 40 times 4 is 160 milliseconds. And normally we expect the QRS complex to be between 40 milliseconds to 120 milliseconds. And in this case, there is an abnormality. The QRS complex is wide. Okay, the next step is to look for any changes in the ST segment. And for this, we'll be taking a look at each of the leads, starting off here in lead number 1. We're going to do this by first drawing the isoelectric line. So let's go ahead and do that. So the isoelectric line is as shown right here. So the ST segment is from the end of the S wave, which is over here. That's also called the J point. So it's from the end of the S wave to the beginning of the T wave. Okay, so let's draw that. Okay, so we see that the ST segment here is below the isoelectric line. And for this case, it is an ST segment depression. And let's now take a look at lead number 2. We'll first draw the isoelectric line. So that's the end of the S wave, that's the beginning of the T wave. And there's also an ST segment depression. Okay, so there's also an ST segment depression in AVR. So here, it's interesting because the ECG waveform has been reversed, and that's because the electrical activity is flowing in the opposite direction. So we see that the ECG wave here has been inverted. So we'll draw the isoelectric line, and so that's the end of the S wave, beginning of T, and we see that if this were inverted, that would fall underneath the isoelectric line. So there is a ST segment depression in lead AVR as well. And it's the same case in V3, V4, V5, and V6. Okay, so we've gone through the 6 steps of interpreting the ECG. And let's see if there are any other abnormalities in the ECG strip here in the bottom. So an important finding here is that there are these tall tented T waves. So we see these tall T waves there, there, and there. And this is present throughout the entire ECG strip. So the T waves are normally supposed to be broad. However, in this case, they're narrow and also they have a peak form. Okay, next, let's summarize the ECG findings. So we established the rate to be 75 beats per minute, and this is because the distance between the QRS complexes was about 4 big boxes. The rhythm was regular. The P waves are absent, and because of this, the PR interval is also absent. The QRS duration was 160 milliseconds, and we saw that it was 4 small boxes wide, and this is an abnormality because this is greater than what's normally accepted, which is 120 milliseconds. Okay, so we found the ST segment depression to be in leads 1, 2, AVR, V3, V4, V5, and V6. Okay, so the interpretation based on these ECG findings is hyperkalemia. And I also want to point out these tall tented T waves as well, which is also an indication for hyperkalemia. Okay, now I want to quickly give you a brief overview of the pathophysiology of hyperkalemia. So hyperkalemia is described as serum potassium levels that are greater than 6 millimoles per liter. Normally, the serum potassium levels are between 3.6 to 5.2 millimoles per liter. However, in hyperkalemia, the serum potassium levels are greater than 6 millimoles per liter. And hyperkalemia has 2 broad categories in terms of causes. So the first category here is because of increased potassium release from the cells. And this occurs in conditions such as metabolic acidosis, insulin deficiency, rhabdomyolysis, or this could just be an artifact because of delayed blood analysis. So what occurs is when you collect blood, and if it's not analyzed within a specific period of time, and if it's just left sitting, the blood cells start to disintegrate and they leak potassium into the serum, and this gives a false representation of hyperkalemia. In this case, the blood sample has to be repeated. Okay, so the second broad category is due to reduced urinary potassium excretion, and this occurs in conditions such as acute and chronic kidney disease, and this is a major cause of hyperkalemia. Other causes include reduced aldosterone secretion, potassium-sparing diuretics, and also drugs such as ACE inhibitors and suxamethonium. And if you remember, our patient was on an ACE inhibitor. She was on captopril. So hyperkalemia has systemic effects. When it comes to the heart specifically, it changes the action potential in the cardiac myocytes as well as the pacemaker cells. So here in the bottom left, there's an image showing the action potential which occurs normally, and that's shown by this solid line, and the dotted line represents an action potential that occurs during hyperkalemia. So normally, if this is our cardiac myocyte, to establish the resting membrane potential, which is phase 4, potassium leaks out, okay, and this makes the inside of the cell relatively negative compared to the outside. And in hyperkalemia, when you have a lot of potassium that's already outside the cell, this process of removing potassium from the cell is impaired. So you don't have as much potassium leaking out, and for this, your resting membrane potential is less negative than what occurs normally. Okay, so hyperkalemia also has an impact on phase 0, and this is the depolarization phase. And as described here in point 2, there's decreased membrane excitability resulting in bradycardia. Okay, next, hyperkalemia also affects phase 3, which is the repolarization phase, and here we see that the repolarization has been dampened, and this results in the tall tented T waves, because T waves represent the repolarization phase of the action potential. So the cardiac abnormalities of hyperkalemia include conduction abnormalities such as right and left bundle branch block, AV blocks, and cardiac arrhythmias such as sinus bradycardia, sinus arrest, ventricular tachycardia, and ventricular fibrillation, which eventually leads to asystole. Okay, so the interpretation tips for hyperkalemia, the first tip here is to look for tall peaked T waves, as shown in the image here, tall peaked T waves, and this occurs with a short QT interval. So the QT interval from the beginning of the Q wave to the end of the T wave. Okay, the next feature is that the P waves may disappear. You see here that the amplitude of the P waves is shorter than normal, and eventually this leads to a loss of P waves. Next, we have QRS widening. So the QRS complex here is greater than 120 milliseconds. Finally, we have formation of sinusoidal waves. So here we have these sinusoidal waves, and these are really wide QRS complexes. And finally, we have ventricular fibrillation as shown here in the image, and this can eventually lead to asystole, which is a flat line. So an important point that I want to make here is that the progression and the severity of the ECG changes do not correlate well with the serum potassium concentration. So when you find these ECG features, all this indicates is that there is hyperkalemia. It doesn't really tell you the concentration of potassium in the serum, so you should not be making clinical decisions in terms of management for the patient based on the ECG findings. Okay, so let's go through a few more examples of hyperkalemia. So here again, when we zoom in, we see these tall tented T waves. So let's identify the QRS complexes first. So here is QRS, and we have this tall tented T wave. So QRS, we have a tall tented T wave. Okay, so our next example here is sinusoidal waves. So here, zooming in again, let's identify the QRS complexes. So this is Q, R, and S, and this joins here with the tall tented T wave, and it's a similar case in this ECG waveform. So that's the QRS, and this is the tall tented T wave, and it's the same scenario for the rest of the ECG strip. And an important point here for sinusoidal waves is you may find these sinusoidal waves in other conditions such as ventricular tachycardia, but you see here that the peaks are more pronounced in ventricular tachycardia, and the tented T waves are also absent. So the major takeaways from this ECG tutorial are that hyperkalemia has a variety of etiologies, and as we discussed earlier, it could be because of increased potassium release from the cells or because of reduced potassium excretion in urine. So the cardiac action potential is the main affected feature, and this results in slow conduction, conduction abnormalities, and arrhythmias. The key ECG findings include tall tented T waves, a widened PR interval, and a wide QRS complex, which is greater than 120 milliseconds. And when QRS complexes become really wide, they present as sine waves. And there's also an indication of ventricular fibrillation, which eventually leads to asystole. So I want to make this important point here again, which is that these ECG features suggest hyperkalemia, but they don't indicate the severity or progression of the condition. In addition, ECG should not be used to monitor response to therapy. Okay, so that concludes our tutorial on hyperkalemia. Make sure to check out other ECG videos on our YouTube channel and Facebook page. And we'll be back with you with another ECG of the Week case next week. Thank you.